Hello, and thank you for checking out FirstcallID, Approach to How to Do an Infectious Diseases Consultation. My name is Paul Bunt, and I'm a specialist in adult infectious diseases and internal medicine. So we'll be spending about the next 10 minutes or so going over some of the key aspects of the infectious diseases consultation for a patient with a post-operative fever. If you haven't done so already, please check out our first session on how to do an ID consultation, which covers a lot of the basics about ID consultations in general, whereas this session really focuses on the specifics of fever in the post-operative patient. Lastly, before we move forward, just a quick note that this content is for educational purposes only. Please refer to current guidelines and use your own professional judgment in clinical practice. So the key points or highlights to the assessment of the patient with post-operative fever. So one is to understand what actually went on with the surgery, either by reading the OR note, speaking to the surgeon or someone who was in the OR, ideally, to have a sense of what happened during the procedure, but just to the best of our ability as usually non-surgeons to understand what went on in the OR. We want to get a sense of their post-operative course. Has it been relatively smooth since the time of surgery, or have things been relatively rocky? When we're seeing the patient, we want to assess for any localizing signs or symptoms that may indicate a source for infection. When we're reviewing investigations, obviously we look at the microbiology, we look at the regular blood work, CBC, and general lab investigations, and we pay particular attention to imaging findings. When we provide our summary and impression, we really want to comment not just on anything that's possible or possible causes of fever, but what are the most likely infectious or non-infectious etiologies. When we provide our recommendations or suggestions, we can suggest any further evaluation that would be required or benefit, any interventions that need to be undertaken, or any empiric or targeted antimicrobial therapy. So here's a fairly comprehensive list of causes of fever in the hospitalized or post-operative patient. And a few things just to highlight. One is that both infectious and non-infectious etiologies exist and need to be considered. Also, it's important to recognize that the fever might be totally unrelated to the hospitalization or the surgery itself, but we really want to focus on the particular surgery and the details of it and some of the causes for fever that this puts the patient at risk for. And I'll probably say this more than once, but the aim when we're doing these consultations is not to list everything that's possible, but to highlight the most important or most likely causes from a list like this. When reviewing the details of the surgery, we always want to document the date and the specific type of surgery. We want to appreciate the indication for the surgery and any intraoperative findings that were noted, as well as any intraoperative complications. And again, this is really worth looking through the operative note and for non-surgeons to get used to reading these notes and picking out the key highlights that are relevant for our purposes. Ideally, you can speak to someone who was in the OR, be it a trainee or the attending physician that was there. In terms of the post-operative course, mostly through chart review, but also through history from the patient or those caring for the patient, right? Have there been any complications or concerns about the patient's course in the post-operative phase? On what post-operative day did the fever arise? And was the fever occurring every day? Was it persistent? Did it come and go, right? So what was the pattern of the fever? And were antibiotics administered at some point? And did the patient's fever actually respond, or did the patient defervesce with the antimicrobials? And our clinical assessment of the patient really focuses on symptoms and signs that might help us localize where the fever is coming from. We'll pay attention to the patient's respiratory status. Have they had a respiratory decompensation or deterioration at some point in the post-operative phase? Has there been an aspiration event? We want to pay particular attention to any lines, tubes, or drains that are in the patient, both where they go and when they were inserted. And that's particularly important when we're looking at tubes and drains and correlating when they were inserted to culture information from those drains. We also want to pay attention to any previous intravascular lines, which could be a potential site for inflammatory changes like a phlebitis or thrombophlebitis, or even a site of infection. We want to pay attention to any particular wound concerns by speaking to the patient's nurse, examining the patient, and speaking to the primary team. And not just the operative site, but also pressure wounds which can develop in patients in the post-operative period. And lastly, patients will receive antibiotics almost in all cases as perioperative prophylaxis, and there is a risk of C. difficile colitis as a cause for post-op fever. So is there anything to suggest colitis or diarrhea? When we're looking at investigations, we'll obviously look at all the information available. The white blood cell count in itself is often not that helpful because many patients will have a high white count or elevated neutrophil count in the post-operative phase just as a result of having surgery. But we do want to look for the differential because there are situations where you might identify a different cell line that's elevated that might be completely unrelated to the surgical procedure. So I've seen patients with elevated lymphocytes who we actually diagnosed with CLL in the post-operative phase when we're just identified or someone noticed a high white count. We want to look through the microbiology, noting the source of the cultures, and really emphasize if the cultures from a drain clarify if it was taken from a new drain as it was inserted versus an existing tube or drain. Tubes and drains that are in the patient will become colonized with bacteria, and it's very difficult to know how to interpret those positive cultures because they could simply represent colonization rather than true infection. When we look at imaging, so usually chest x-ray looking for pulmonary infiltrates, if they've had abdominal surgeries, looking for any collections, localizing and identifying drains. If a patient's had orthopedic procedures, we want to look at the x-rays and images just to identify the prosthetic material and any changes around the prosthesis, such as fluid collections, which could again be a source for the fever. From this information, we come up with our summary impression. We list the most likely causes of fever, and we include, as I said, both infectious and non-infectious considerations. You know, I say try to avoid the tendency to list all potential causes. Right? Anyone can copy and paste a list of causes of fever. Right? The consultant role is to narrow and organize the list for this particular patient in this situation. And then we provide our recommendations. So are there any additional microbiological studies that we would request? So cultures of the blood, urine, sputum, wound. Does the patient need a C. difficile assay to be sent? Is there any additional imaging that will be helpful, right? So chest x-ray, even a CT of either the chest or intra-abdominal CT if there's had abdominal surgery. You can consider echocardiogram if endovascular infections or endocarditis is on your list. Doppler ultrasound if you're considering DVT, which is not the most uncommon cause of a postoperative fever, probably not at the top of the list, but something to consider. So is there any other imaging that we'd recommend? In terms of interventions, have you or has the team identified or has there been imaging to identify a post-operative collection that requires drainage or would benefit from drainage if feasible, right? Or is there a potential source or focus that would benefit from debridement if feasible? Do we think that the source is potentially an intravascular line, in which case we ideally want to remove that line again if it's feasible? In terms of a recommendation on antimicrobial management, the decision of what to start or whether to start or withhold antibiotics in a stable febrile patient is very nuanced. It is reasonable to observe stable patients, but have a plan of what to start if they deteriorate. And for this, we want to look back at their colonization as well as recent antimicrobial exposure to help us decide what we would start. The one caveat to that is, I've often been told if you write it, they will give it. And so if you actually include in your note, if the patient deteriorates, add this antibiotic, it'll be very common for the primary team to just simply start that antibiotic. So sometimes we'll say, please contact us if the patient deteriorates and we can discuss antibiotic selection at that point. So as we wrap up, I'll just show you again the key points or highlights of our assessment of patients with postoperative fever. I'll just make a few other small points here. So the first is, as a non-surgeon, it's very important for us as ID consultants to try to understand the basic principles of the particular surgery and any known or potential complications. The next is to approach the assessment with the aim to determine the most likely or significant potential causes for the fever, rather than coming up with an exhaustive list. Then the last point is just, sometimes when we see a patient with post-op fever, we don't get an answer. We do our investigations and we never really get to the bottom of it. And you might lose sleep over this, but it does happen. I think you can accept that, but also at the same time, you can't just ignore a fever. It's still up to us to try our best to come up with an explanation or cause for the fever when we're seeing it. Some references that I found helpful in framing the approach to post-op fever. So BMJ best practice evaluation of post-operative fever and evaluating post-operative fever, a focused approach, both with links below to help complement what we've talked about today. So that's all for now. I'm Dr. Paul Bunt, and I want to thank you again for watching. Please share any feedback you have about the session or First Call ID as a whole, either below or by email at firstcallid@gmail.com. And if you found the session useful, tell a friend. Take care.